Well, welcome to this this webinar. This is our monthly webinar, and I wanted to. And this seminar series or webinar series is really particularly made kind of geared towards the DAPSE class that's not going through. But everybody's welcome. If you're not in the current DAPSE class, that's fine. So you're welcome to be here. But this is really geared toward that. So I developed the level of teaching kind of commensurate with where that class is. And one of the things I want to talk about is infection. And the reason why I want to talk about infection is because this is one of these things that you're going to encounter in your practice. You're already encountering it all the time, and you may or may not be aware of it. And but if you get a leg up on this, it'll really help you. And it is a few modules down the road before we really delve into this. So I wanted to give you a little bit of workable knowledge with this basis right here. So let's get right into it. First thing I like to talk about is the two-funnel system. And when we talk about the two-funnel system, really what we're talking about is this. As far as the chiropractic internist, we really wear two hats. And one of those hats is the diagnostic hat. That's the traditional medicine internal diagnosis. Somebody comes in, you go through a differential diagnosis. You know, we start with signs, symptoms, history. We do a physical exam, and that leads us to systems or what organs or tissues could be involved. And then we go through a process of testing, which looks like labs, imaging, or whatever that is, and that'll help us narrow down. This is walking through the differential diagnosis, and then we get to name that disease. Is the name of that disease psoriasis? Is the name of that disease celiac? Is the name of that disease myasthenia gravis? Whatever it is, we're getting to the name of that condition. So part of being a chiropractic internist is to be able to recognize these organic disease processes. Now, the reality is most people that we see and most people that go into doctors' offices don't have a named disease. So if you have a named disease over here and normal is over here, most people are somewhere in between. They're not sick enough to have a name to it, but they just don't feel well. Now, certainly we run across a lot of people who do have named of conditions, and we go through processes of how to deal with those things. But as a chiropractic internist, port of entry, primary care physician, we really want to be adept and have the ability to be able to discern the severity of the condition to see what our level of care needs to be with that person. The other hat is the care model. The care model is exactly the same thing. We have signs, scenes, history, and that leads to a physical exam. And then the physical exam leads us to what systems, what organs or tissues can be involved. And that's where we get the bail them out, you know, blood sugar dysregulation, anemias, oxygen deprivation, inflammation, infections, liver, GI, microbiome, estrogen, you know, a whole bunch of things like this that we look at from a systems. And if somebody has a thyroid issue, whatever, we work through that, and then we run labs, we run labs and specialty labs, not just blood, but primarily blood. We do other things, but we do that not to name the disease. We do that to figure out what is driving this condition. Even if it's a named disease process, we still want to know what those drivers are. What is at the root, and then that's how we develop a care strategy. We actually might find, in many cases, we might find it looks like this. So somebody comes in, they have high blood pressure, and this looks like a tree if you didn't recognize it, and maybe they have, you know, fatigue. They have obesity, and they have insulin resistance, and if it's a male, they have low testosterone, or if it's a female, they have high testosterone or low testosterone. So the funnel that I'm describing over here, the care strategy, is really at getting to what is at the root of what's driving these things. See, medicine is really the approach of, oh, you have high blood pressure, so let's get you a blood pressure medication. You have obesity, let's get you an obesity medication. You have low testosterone, let's get a testosterone medication. You have insulin resistance, let's do a, you know, some metformin and things like that. So that's really the practice of medicine. It's an outside-in approach. You're taking the downstream of a problem and you're trying to treat it with some kind of drug. Now, I'm not saying that's a bad approach in some cases. And I'm not trying to, split hairs here. It's always best to go upstream, but sometimes somebody's disease process has gone so far, they do need a little bit of help, but we always want to see what we can do to get down to the root of the problem. Many people are on medications today, prescription medications. They start on 1, 2, 3. First thing you know, 5 years later, they're on 4, 5, 6, and 10, 15 years later, they're 6, 7, 8 different medications. They just keep on piling themselves because they've never taken the time to get to the root. And that's really what we do as a chiropractic internist. First, we do our diagnosis, internal disorders, and the second, we work through this model. The reason why I'm explaining this so much is because when people come in, chronic infections are very common. They're very common, and they very commonly cause problems, and they are missed all the time, all the time. And it's not really the medical doctor's fault so much that they miss them, because really what a medical doctor is looking for are acute infections. They're looking for something that's going to kill somebody right now. Somebody has pneumonia. Is it marching on? Is it getting life-threatening? They have acute phase reactants that are through the roof. All these different things, and so they're going to do that. But when an infection goes what we call subacute or chronic, then it begins to go under the radar, and they don't see it. Why is that? Well, the white blood cells don't go sky high. The neutrophil lymphocyte balance gets a little bit off, and there's some other nuanced things. I'm going to show you that some of these things I learned, but some of these things I just become to understand and developed ideas over time of sitting in the chair of seeing people, seeing these infections and seeing them go. So what I want to do is I want to take those years of experience of me sitting in a chair going through these things, and I want to impart that to you. I'm going to go through and we're going to give you a list of labs that you can look at that'll help you discern whether somebody has a chronic infection. And if they do, when you employ some type of strategy, you can always come back and see if you're winning or not, which that's important. All right, so metabolic clinical decision tree. Of course, patient presents, we do our history forms like we talk about. We figure out what issues, presenting symptoms prior to the physical exam. We do the physical exam, kind of walking through that process. We order the labs, and then we develop a strategy. And the ultimate is developing long-term life strategy to maintain continued progress. All right, so let's just take just a small detour. We'll jump in. I want to show you this. We went through this slide a few months ago in the DABCI modules, but I want to reiterate. Several recent studies have described a deterioration of physical exam finding our skills among modern physicians. Reasons hypothesized for this change are improvements in technology and time constraints. So in other words, they've got a lot of fancy equipment, right? And I don't mean that to be derogatory, but they've got, MRIs, they've got CTs, they've got things at their fingertips. They can just do that kind of imaging. And not only that, they have constraints of time. Like you have 15-minute window. And as well as I do, if you have somebody who has a complex case, you're not getting them in there and out of your office doing the type of work we're doing in 15 minutes. It's not going to work. Of course, you're going to charge appropriately, and they're going to be happy to pay when they get the service they need. Poor physical exam skills are a noteworthy threat to patient safety, as they can lead to incorrect as well as misdiagnoses, causing delays in timely implementation of life-saving treatments. I don't know how many times this has happened, and I don't want to just tell war stories and all my greatness, because it's not about that. I'm just like everybody else. Anybody can miss on any given day. But I have had a number of cases that doctors were just stumped on, and not because even I'm a great diagnostician, but I just go through the funnel, work through the model that we teach, and it leads to a conclusion. I remember one case come in, he'd been a mortician for I think something like 30 to 40 years. There he was, 65 years old. He's getting ready to retire. Him and his wife getting ready to buy an RV, or maybe they had bought an RV. They're going to travel all through the country. All of a sudden now he has a hard time breathing. He can't get a good breath. So he'd been like 3 to 6 months. He'd gone to different doctors. And he really came to me not for the purpose of me treating his condition so much, but you develop a reputation over time. He actually came to me because he wanted to understand what the heck was going on. Well, we listened to his lungs, and we did a physical exam. When we did a physical exam, this is something we found. So here's the left lung, excuse me, that is the right lung. This is the left lung, and the liver sits right down here, right here. Then we've got our rib cage. Well, what happened was his liver was very swollen. And when I pushed on it, it felt hard. Something was wrong with that liver, and it was bigger than just oh, you got a little bit of a swollen liver. It was easy to see. Guess what? Nobody ever looked. Nobody ever, got him down on the table and did a basic abdominal exam. So I went in there and palpated his liver, and it was big. Well, there's something that I know about the liver because I know physiology, and this is what you learn in the DAPSE program. So the liver has what's called a hepatic vein. That hepatic vein goes into the inferior vena cava, which feeds into the heart, which goes into the lungs. Well, one of the things that happens is when the liver has some kind of pathology, that doesn't flow right, and it can give you shortness of breath. And that's exactly what he had. So what I did was everybody was looking at the lungs. They said, oh, you can't breathe, let's listen to lungs. I don't hear anything. Did a CT on the lungs, nothing showed up. Nothing showed up anywhere. I don't know if they did CT, but they did whatever workup they did. When he came to my office, they still didn't know what it was. So I sent him out for a basic ultrasound of the liver because I suspected there was something bad going on in that liver just because I worked through the process. And sure enough, unfortunately, he had hepatic carcinoma. He had actually cancer in the liver from probably breathing all those nasty fumes from being a mortician all those years. Unfortunately, I don't think he made it really much longer. But anyway, I just wanted to say that just basic physical exam skills are going to take you a long ways. All right, so that's enough of the advertisement. By the way, I did want to say, and I have it right here, and I want to make sure that we don't miss this. But May 16th and May 17th, we are doing an immune system autoimmune. We'll go through allergies and autoimmune. We're going to do a 12-hour module on that. If you've never gone through an autoimmune module with us, I highly encourage you to do that. We're really going to go through the ins and outs. You're going to have not only an understanding of what drives autoimmunes, but you're going to have a workable model of a strategy on how to work through history, physical exam, how to order the labs, how to interpret the labs, how to build a care strategy, and how to walk through that. You're going to really learn a lot about autoimmune. Really excited about that. That's going to be May 16th and 17th. Okay, so let's get on with chronic infection. The first place that we start is if you have a chronic infection, you always think of history, physical, and labs. All right, so let's look at it from this way. So no possible clinical presentation. So when somebody has a chronic infection, many times they can come in and they have fatigue. Not always, but and sometimes people are so resilient that they might be fatigued, but they can't really tell it because their body just is so strong, and their willpower is going to move forward. They're not going to admit they're tired. But fatigue is a very common symptom when somebody has a chronic infection. Brain fog can be there. Depression can be there. Non-mechanical pain. This is a big one. Somebody says, oh, my hip hurts. Where's it hurt at? I don't know. You bend them this way, you bend them that way. You twist the hip this way, you twist the hip that way. You push on it. You can't reproduce the pain. That is a non-mechanical pain. If you have a non-mechanical pain, it is a high suspect for infection. Now, it can be autoimmune. It can be an inflammatory process. You have to work through the model, but you certainly want to put an infection, chronic infection, or even acute, subacute infection on your list. Chronic joint pain. Somebody just has joint pain all the time. Now, for sure, I've seen people, sensitive to eggs or they're sensitive to dairy. Dairy sensitivities love to go to the knees. For whatever reason, the milk protein looks very similar to the cartilage in your knees. And when you're sensitive to milk, you get antibodies, and those antibodies like to go right down to the cartilage, and over time the antibodies become smarter and smarter, and the first thing you know, now you're attacking your cartilage in your knees. Very common, milk sensitivities and chronic knee pain. But if you have chronic knee pain, guess what? It can be infection. That's the reason why we go through this process. Here's signs, symptoms, history. We do our physical exam. What systems could be involved? Well, it could be a chronic infection, so we're going to check that out. It could be inflammatory. We're going to check that out. It could be autoimmune. We're going to check that out. Could be food sensitivity. We're going to check that out. How are we going to check that out? That's the next step where we run our labs. I'm going to show you labs here in a few minutes that will help you work through this this maze of whether you're having a chronic infection. Chronic itching, mystery illness, autoimmune disorder. Many autoimmunes are kicked off by viruses. Chronic elevated temperature. Somebody's always, 99, 100. Chronic cough, chronic lymph node swelling. Rapid downturn of any kind. This is a big one. If somebody is going along and everything's going okay, and all of a sudden, man, they just fell off the side of a hill. I don't know what happened to them. I don't know what happened to me, but man, I just feel terrible. You have to suspect an infection. Here's what most people think, and I want you to catch this. This is a very important point. So somebody will think that, oh my goodness, 2 weeks ago, I just started feeling terrible. I'm fatigued. I can't hardly move my arm, can't raise it up out of bed. My joints hurt. I feel terrible. And you know what they think? I must have cancer. Cancer doesn't do that. Cancer is a very slow growing, most usually. It's a slower process. You're not just wake up one day and all of a sudden you're tired and fatigued. It's going to be a slow walk down that hill. Infections go fast. Cancer usually goes slower. So that's a hint for you. Somebody has a very quick or rapid downturn in their symptoms, or maybe you've seen them for 6 months and everything's going great, and all of a sudden they come in and I don't know what happened, but I'm just as bad as I was when I first started. Guess what? That's a clue that they've got some kind of infection somewhere. You want to watch that. All right, so that's worth the price of admission to this whole program right here, learning that one right here, coming to the webinar. All right, so no possible locations for infections. Oral sinuses, we're going to walk through this. We're just going to go through each one of these. So let's talk about historical findings. As you know, fatigue is probably the most common symptom people are going to have when they have infections. Why? Because the immune system is going after the infection. It's just going to drag you down. Cortisol is going to change. Everything's going to change. So we've already gone through these. All right, so suspect a virus in the following. If somebody has a history of an autoimmune disorder. Now, not all autoimmunes are kicked off by viruses, but guess what? A lot of them are. A lot of them are. Viruses you get infected with the virus, and then that virus, if you look at the amino acid sequence of that virus, it looks very similar to some tissue in the body. So this will be the amino acid sequence, and they'll look similar. So your white blood cells will go after the virus and build an antibody. And then all of a sudden those antibodies will begin to cross over, and they do something called molecular mimicry, which you can kind of figure out what that is. So it's mimicking the virus. It thinks it looks like a virus. By the way, if you look at it, the Epstein-Barr virus looks a lot like some of those pieces of the thyroid. So it's not uncommon to see somebody have Epstein-Barr go into Hashimoto's. Also, stuff in the liver. Liver pathologies, different things like that. Epstein-Barr. Epstein-Barr is a big menacer. All right, so chronic fatigue, suspect a virus. Chronic fever of unknown origin. Swollen lymph nodes, symptoms vary. Mystery illness, I don't know what the heck that is. I've never seen that. Didn't see that in the books when I went in school. Well, that's an indicator that you might be looking at a chronic infection. All right, so possible symptoms of bacterial infection. All right, so if you have an acute right now, these are not hard to find or see. And I say this kind of funny, but even medical doctors can find these, right? So, a person comes in, they have fever, chills, pain, achy body, rapid onset, malaise, rapid downturn, return of old symptoms. These can be an acute infection. Subacute can still look like fatigue, brain fog, joint pain, non-mechanical pain, cognitive decline, right, over time, cognitive decline. So, all right, so somebody comes in and they have fatigue. They've been chronically fatigued for the last 2 years, right? So what's the first question I ask if somebody's had chronic fatigue for the last 4 years or less? Did you have COVID? And some will say yes, some will say no. And then those that say no, were you ever around anybody had COVID? Yeah, my wife had COVID, but I didn't get it. Well, guess what? You probably did. But here's the deal. I don't want to detour too much from the program, but I want to show you something real quick. Inside your cells, you have the mitochondria. The mitochondria is where you convert food into energy. I don't mean to be, demeaning. I know you know this, but just to kind of just to reiterate, so on and so forth. Well, as it turns out, viruses love to change the machinery of the DNA. So you get this virus that comes on here. Sorry about that. I'm put my virus right here. And that virus has this little viral capsid in it, just like it's almost like a lunar lander. That thing comes out like that, and that goes right into the DNA. What does DNA do? DNA makes proteins. That's the job of DNA. The DNA was going to make all the proteins that that cell needs to work. Proteins are the things of life. If you don't make proteins, you don't live. So the DNA is cranking out these proteins. Well, guess what? When the viral capsid gets in there, and all of a sudden it starts making proteins that look like a virus. Now all of a sudden you're making a lot more of these guys. Well, here's the next part of the story, is that the viral capsid also goes into the DNA of the mitochondria. So the mitochondria has its own DNA that is separate and distinct from your DNA. So it's thought that many years ago that we were infected by bacteria, and we have good bacteria in our body. As it turns out, mitochondria is a precursor. Its precursor is a good bacteria that got in our body and helped us and worked together with us to be able to convert food into energy. So that's the going theory. So here's the thing that we do know for sure, that DNA has its own separate distinct DNA. I'm sorry, mitochondria has its own separate distinct DNA. It's not the same DNA that's in that makes up your cell except proteins. Well, guess what? COVID loves to get in there and screw up that DNA of the mitochondria as well. And so now you have mitochondrial dysfunction. In fact, many of these chronic viruses that are in there, the reason why you're fatigued is because viruses love to mess with the mitochondria. So somebody has chronic fatigue, we always think virus. Are there other things that can cause chronic fatigue? Absolutely. Anything that screws up the brain can cause you to have chronic fatigue. But I'm going to say that you have to look for chronic infection. These chronic infections many times are viruses. Not always, but many times they are viruses. All right, so here's some common places. Somebody comes in, they're fatigued, non-mechanical brain, joint pain, whatever it is. We're gonna start now thinking, now where could it come from? It can come from anywhere. Is it in the oral cavity? That's a big one. ENT, is it in the ears, the eyes? Is it in the nose? Is it in the throat, right? Is it the bladder? You'd be surprised if you do urinalysis on post-menopausal ladies. You're going to be surprised at how many ladies have this low-grade leukocyte esteraceous white blood cells in their urine because they have a chronic E. coli that's stuck to the wall of the bladder. There's not enough E. coli in there to show up bacteria in the urine, but there's enough in there to cause irritation where leukocyte esterase and white blood cells are. So GI, vaginal, prostate. Prostates are hard because they're hard to deal with because it's hard to it's hard to get, like if you take herbs and different things, it's hard for them to land in the prostate. All right, so joints, skin, nails, systemic, brain, these are all possible places that you really want to think about. All right, so I'm going to talk about the labs, and then we're going to back up to some specific things that we can look for in places. All right, so now the white blood cell count is very sensitive. We love it because it's very sensitive, but the problem with it is not specific. What does that mean? That means that if you have high white blood cells or if you have low white blood cells, it doesn't tell you absolutely, oh, it's this or that. It just says you have high, here's if it's a pattern of what's going on, right? So it is sensitive. If you have an infection, it's going to manifest somewhere in those white blood cells. Problem with it is there are many things that can actually move the white blood cells around. Like you could have a chronic virus, and chronic viruses love to have the white blood cells below 5. They like to be somewhere between 4 to 5 when you have chronic virus. Now, don't write that down as a rule, because then somebody could also have an infection in an old root canal. They did a root canal. Dentist talked them into it because they think it's the greatest thing since sliced bread. And they're terrible. They get a root canal, now they get an infection in there. It's a bacteria. So the virus would like for that white blood cells to be at 4.5, but the chronic bacteria in the root canal would like it for it to be 7. So guess where it's at? It's 5.5, and you think it's normal, and so does the medical doctor. But guess what? You got two things going on, right? And that's just an example. It could be anything, right? So you could have 3 or 4 or 5 different things going on. Now, just so you know, that's the reason why I always suggest this, that when you first start, this is day 1 of care. When you first start with somebody, after 4 to 6 weeks of care, you've gone through, you've done some liver cleansing, you've done blood sugar boot camp, you found their food sensitivities, you've got inflammation down. In 4 to 6 weeks, you'll want to come back and run that CBC with differentials again. And here's what you're going to find in some of these cases. You will find that the white blood cells and even the neutrophil lymphocyte balance look perfect on their first go around, even though they felt bad. Now, 4 to 6 weeks later, they're feeling better, their energy's better. By all reasoning, they're better. But you do a white blood cell count, now all of a sudden their white blood cells are at 4.5 and their lymphocytes are at 45. They've got a chronic virus. But guess what? You couldn't see that to start with. They're feeling better. Why? Because they're not eating the crappy foods. You got them on food sensitivities. You got their liver working better. You got the system chugging along better. They're going to feel better because it took stress on. But guess what? It's took stress off. But guess what? They still have a problem going on, right? So they still have a problem going on, and over time they're going to feel that. And then we have to go through and work with that. And I say sometimes I'll give you a caveat to that when we go there. All right, so let me show you this. This is just basic. All right, so neutrophils, if you're not fighting anything, neutrophils will generally be at 60 and lymphocytes at 30. But I caution this because, as I said, you could have somebody who has an infection in an old root canal that has bacteria in it, and then which is going to raise the neutrophils, and then you also have a chronic Epstein-Barr, which is going to lower neutrophils, and so now you're balanced. Now you're at 60, but you do have an infection going on. So that's what I'm saying. You have white blood cell count, neutrophils, lymphocytes, very sensitive but not specific. That's the reason why you always have to work through these models to see what's going on. So we do not rely on just simply looking at white blood cell count and neutrophils. I'm going to give you some other things, and I got to tell you, these things I'm getting ready to share with you are absolutely golden. Absolutely golden. All right, so anytime you have monocytes above 7, and they're chronically above 7. So in other words, you do a blood test on somebody today, it's their first time in, and they're at 8.5. I don't think much about that. Definitely not going to declare a chronic infection. If I come back in 6 weeks, I come back in 6 months, and it's still hanging at 8.5, then I'm going to tell you they probably have a chronic infection going on. Or their first day, they're at 8.5, and you say, Mrs. Jones, can you bring blood work next time you come in that you've had over the last 3 to 5 years? And they do, and they have 3 samples, and all of them are around 8.5 on monocytes. Guess what? They probably have a chronic infection, right? All right, so TSH, this is a big one right here. If TSH is lower than 1 and they're not on a thyroid glandular, they're not on levothyroxine, nature thyroid armor, they're not on any thyroid medication, and make sure you ask them, are you on anything for your thyroid? If they're on nothing for their thyroid and TSH is below 1, it fits a pattern of infection. It could be acute or chronic infections, either one. We want to talk about that just a little bit. So here's the pituitary. Oh, there's the pituitary. And here is the hypothalamus. So the hypothalamus sends thyroid releasing hormone. My thing's having some challenges here, I see. There you go. And then your pituitary sends TSH down to the thyroid, right? So what happens Bacteria can do this too, but there's a place on the hypothalamus. It's called the periventricular nucleus, the PVN, periventricular nucleus on the hypothalamus, that viruses and bacteria, mainly viruses, but bacteria can land there too. They like to land there, and when they do, they slow the gears down and they lower the thyroid releasing hormone, which lowers that TSH. TSH, we really want that to be about 1.8 to 3.0. When it goes below 0.1, that is consistent with what we call a tertiary hypothyroid. Tertiary means it's not coming from the thyroid, it's not even coming from the pituitary. It's even higher than that. It's tertiary. If it's from the pituitary, we call it secondary. Like somebody has hypoglycemia and it causes them to have pituitary fatigue. I've shown you the model with the cortisol and how you get the pituitary fatigue, and then you have a secondary hypothyroid. Thyroid's fine, but you still have all the symptoms of hypothyroid. Well, if you have an infection, you can have all the symptoms of a hypothyroid, and sometimes it's even worse because your thyroid's fine, but your brain is just not telling your thyroid to make thyroid hormone. And what does thyroid hormone do? It activates the DNA, and we know that DNA is in your cells, and DNA, of course, is in the mitochondria. So if the thyroid hormone is not doing its job, then we're not going to be making proteins as efficiently for the cell, and the mitochondria is not going to be kicking in. You're not going to be cooking. You're not going to be converting food into energy, as you should. You're going to be tired. Now, some people have an extraordinary blessing of a gift of lots of mitochondria, and so even if they have a low thyroid, they don't feel it that much, because they make up for it, but a lot of people don't. All right, so if you have a TSH that's lower than 1.0, no thyroid medication, you must put in your pattern that fits a pattern of a chronic infection. Here's another one. Platelets have what are called toll-like receptors on their outer membranes. What does that mean? A toll-like receptor is a pattern recognizer. It recognizes a pattern of specific types of bacteria. So if the platelets are sensing some kind of microbe in the environment, sometimes it's this inflammation, but if it's sensing some kind of microbe in the environment, it will elevate its number of platelets, and you'll see those platelets go above 250. Now, if you have somebody with platelets of 375, does that mean that they have a chronic infection or they have an acute infection? Well, it doesn't necessarily mean that, but it can. It fits a pattern of that. So if you have somebody comes in, they're fatigued, they have joint pain, their TSH is lower than 1, and their platelets are 325, I'm going to say all of that fits a pattern of a chronic infection. And guess what? Their white blood cells are going to be normal, and their neutrophils, lymphocytes are going to be normal. They're going to go to the medical doctor, and the medical doctor is going to say, no problem, nothing to see here. Move along, right? Put yellow tape around it, nothing to see, right? When the fact is, they've got a chronic infection in their mouth, they got a chronic infection in their gallbladder, they got a chronic infection in their bladder, they got a chronic infection somewhere, and that's why they feel bad, right? So that's why my dad used to say, it's not hard to be number one. And he wasn't braggadocious when he said that. He was saying that out of, hey, if we'll just do this work good. And this is not me or you just being a hero. This is just doing good work, working through those funnels, right? CRP. Anytime CRP is above 1, it fits a pattern of infection. Now, I will tell you, out of all of these are good. The top 3 are probably more specific for chronic infection. And elevated CRP is there. It's there, but just general inflammatory processes can do that with CRP too. Okay, so let me say it differently. If monocytes are normal, TSH is normal, and platelets are normal, white blood cells normal, patient feels pretty good, maybe they're having some joint pain, and their CRP's above 1, but it's not out of clinical range. Let's say it's 8 is clinical range. So let's say it's 3 or 4 or 5. I'm not thinking that necessarily fits a pattern of infection. I'll still keep that on my radar, but I'm not really thinking so strongly. But let me show you another scenario. The patient is fatigued, their TSH is lower than 1, platelets are 275, CRP is 3. I'm going to say, yeah, CRP is probably or could be related to that pattern that looks like infection. All right, so these are also things that are associated with chronic infection. I will just say that you don't see them as much. So anytime you have an RDW that goes above 13, you begin to get a bit suspicious. Now, according to Harvard Medical School, if you have a RDW that's over 14 and it constantly stays over 14, that is a high risk of chronic degenerative diseases of all kinds, dementia, cardiovascular disease, cancers, all kinds of different things, right? So, and then I'll touch on the, we want to get to some cases, so I'll touch on this. Let me just say this real quick, that acute phase reactants. So CRP is acute phase reactant, ferritin and fibrinogen are acute phase reactants. What does that mean? When you have a particular bacterial infections, viruses don't do it so much, but if you have a bacterial infection, you can have massive increases in CRP, ferritin, and fibrinogen, and that happens when you have a more significant type of infection. In fact, one of the things that we used in our office, we saw a lot of COVID cases, did a lot of vitamin C IVs, and really think we saved a lot of lives. The thing I'm most proud of is that out of all the time, we had hundreds of patients come in with COVID. And I'm talking about patients that were not sick enough where they accept them in the hospital, but keep in mind, they didn't accept in the hospital until they were dang near dead. And so we had a lot of those patients, and some of them were Amish and different things that they just came to us and they didn't go to the hospital. But you know, one of the things I'm most proud of is we didn't lose one patient. We didn't lose one person with long COVID who came in and did our protocol. But one of the things that we looked at to see, not the only thing, but we looked at that CRP. If that CRP on a COVID case went above 75, then we were cautious with that patient. In other words, we may do 1 or 2 IVs on them, but we're going to check that CRP in about 3 days. We got to see that coming down. If it's not coming down, we might have to ship that person out. Now, we also looked at pulse ox. We looked at a few other things like that as well to give us indicators. And so, but anyway, at least I think we probably sent about 10 people out, 10 or 15 people out by the time it was done. I remember we had one guy walk in. He walked in, wanted to get an IV. He walked in, he waited too late. He walked in, we didn't even let him through the reception. He came to the reception room, and you know, one of our doctors there got a hold of a nurse and said, "Oh, nope, turn that one around." We made a call to the hospital, say, "We got a guy coming over." All right, so let's move ahead. Common blood lab findings for acute bacteria. So neutrophils can be elevated, but guess what? Not always. Some GI infections I find that are bacteria can flip that upside down. You can have lymphocytes higher, neutrophils lower. Also, the other caveat, if you have straight Lyme disease loves to take neutrophils down and lymphocytes up. Now, Lyme disease is bacteria, but its own little thing, right? It's a spirochete. It has a spiral. It's shaped like kind of like this, like a corkscrew, and it's different than your regular bacteria. So it acts a little different, and so your immune system goes after it a little bit different. So, but anyway, so you could have that. Now, many people with Lyme disease have other co-infections, which can change that, make the lymphocytes higher. So lymphocytes elevated, neutrophils decreased in some cases. GI infections, not all GI infections. In fact, when I see things like H. pylori, I usually see neutrophils high. Acute phase reactants are up, and the acute phase negatives, right? Cholesterol can go down with a bad infection. Albumin can go down. When albumin goes down to 3.5 or less, and somebody has an infection, then you really want to consider a referral for that patient. You want to consider a referral to get that patient to do some heavier duty antibiotics, things that we're not going to have the access to. So you don't want that albumin to get to 3.5 or less, because you can lose patients that way. I don't over dramatize it, but you want to be careful. You want to make sure you're careful with that. Okay, that's just information for you to know. Don't get all freaked out about it. Just run the blood, and then you shall know. All right, so let's move forward here. All right, common lab findings, chronic bacteria. Okay, I think this is enough. Oh, I want to point this out. Altered iron. Bacteria loves to seal iron. So sometimes you'll see total iron either low out of clinical range or high out of clinical range. Now, if I see total iron that's out of clinical range, up or down, and I don't see anything else going on, that's enough for me to say there could be a bacterial infection going on here. There could be a bacterial infection going on here. All right, so here's just some places, right? So right here, that could be periodontal. See that right there? See how that gum is receded? That could be periodontal. One of the things that you can do, okay, your tonsils, you got white spots. White spots are white blood cells. You look in the ears, you know, if you have bulging, that's, you know, fluid on the ears and so on and so forth. Let's go ahead and go through a couple of case studies, okay? All right, so 39-year-old male presents with dizziness, right? So the patient had suffered vertigo for 6 weeks prior to the visit into our clinic. Vertigo described as equilibrium off. Prior to entry, patient had seen a medical doctor and infection was ruled out. So medical doctor looked at it, said, no, there's not an infection here. These are the important exam findings. Vertigo was unprovoked by movement. Guess what? That can vestibular neuritis or vestibular infection. That can so let me back up because I've kind of botched that a little bit. So if somebody moves their head real quick and they get dizzy, you want to think of things like, do they have cervicogenic, right? Do they need their atlas set, get their head on straight, get that dizziness better? That's a very common cause. But you can also have benign paroxysmal positional vertigo, BPPV, one of the crystals gets knocked loose. That's when you turn your head and boom, you have the symptoms, right? And so that's that. So it's provoked with movement. But on those cases, you know, it is mechanical, so you can see it, you know what it is. But if it's unprovoked, just out of nowhere it comes, then you got to think, well, what the heck's doing that? Well, infections can do that. Well, I looked in the ear, and the left ear had white spots on the eardrum. Oh, this is getting suspicious. Then we ran our blood work, and calcium was elevated. Well, I didn't really put it in there, but one of the things that you'll find, not for infection, but when somebody has inflammation, a lot of inflammation that can be caused by infection, but other things too, calcium can bump up high and it can go just a little bit above that clinical range. We don't think when calcium gets to 10.5, 10.4, we don't think cancer. I don't even think hyperparathyroid. I don't think any of those things until it goes north of 11. Then we put that in the pattern. At 10.4, I think, well, you know what? There might be a little bit of inflammation going on here, and that's probably the most, you know, likely source of that. White blood cell counts 8.2. Well, guess what? Anytime, catch this. I want you to. This is important. Anytime your white blood cells are above 8, you must suspect an infection. Now, does it mean absolute infection? No. It highly suggests an infection, but other things can do that too. Autoimmune can do that. Cancer can do that. A lady being pregnant can do that. So there's other things that can do it, but the most common cause of a white blood cell count at 8 and above is an infection. Well, guess what? The medical doctor doesn't even look at it until it's 10.8, right? So you could be at 9.5, and look at these neutrophils. Neutrophils should be 60, and lymphocytes 30. They're 75, 17. You know what a medical doctor would say when they look at that? They'd say nothing to see because the white blood cells count's not high enough, and that's not high enough. But I will guarantee this is a bacterial infection. I know for different reasons. I've got the history, I've got the physical, and I've got the lab, right? So remember, you know, signs, symptoms, history. What do we have? We have vertigo that comes on unprovoked. Wow, that sounds like non-mechanical pain, non-mechanical things, which infections fit in that category. Physical exam. He had fluid in the ears, and he had white spots. Okay, that's getting curious. Then what systems could be involved? Well, we want to think about infections. We ran our white blood cell count as above 8. We saw the neutrophils at 75. That is a bacterial infection. Platelet count is 140, so that wasn't a problem. But guess what? Platelet count should be at least 160, and that's probably a liver thing that's going on with him. So what's going on with that liver? I don't see much there. I don't see much there. So that's okay, because you don't always see all the patterns. See, the TSH looks fine, all that looks fine, but this is going to be a bacterial infection. All right, so here's a chief complaint: excessive mucus from the lungs, fatigue, depression, SIBO, right? So let's just look at it. She's not on any thyroid medication. Look at that TSH. That fits a pattern, right? There's something else I did not put in there, and I apologize. I apologize that I did not state this before, but I should have. Going back to those common things that cause and that say infection. If you see protein that is 8 or higher, 8, 8.1, the most common thing, and I mean by far the most common thing, is going to be an infection somewhere. So I did not put that in this category here, but it really should have gone in this category here. So I'm going to put it right here. Protein over, I can't even spell it now. Protein that's over 8. Now, dehydration can cause protein to go high, but not that high. Inflammation is doing that for some reason. Of course, cancers and catastrophic things can make protein go that high as well, and you have to see what patterns fit. But by far, the most common pattern is going to be the bacterial. Now, look at this one right here. So platelet count is above 250, neutrophils at 70, so that's it. The C-reactive protein is elevated, TSH is low. That's a bacterial infection for sure. Just an absolute. All right. Okay, so I think this is 2 months after care. Their TSH was 0.27, to start with, and now it's 2 months later, it's 0.88. She had a chronic infection in those lungs for years, but this is showing me that she's beginning to make some progress. Even her platelet count came down a little bit. Look at this. White blood cell count was, let's look at this. I'm sorry to bounce you around. White blood cell count was a 6.7 initially. What's going on here? The immune system is giving up. It's not fighting it. It's not winning. I'm going to have to plug in my computer. It's not winning, so it is giving up. So you're getting a weaker white blood cell count there, and so that's a normal thing, right? Because after time, your immune system is going to say, "What the heck? We can't do anything with it." Well, guess what happened here? And I think this is really good. Let's go to this one here. Now look at this. It was 6.7. Now the white blood cell count has gone up 1.7 points. That's a big deal. That means that immune system's getting more vigor. It's going after this thing. We're making headway, and the patient's getting better. C-reactive protein was at 15. Now it's at 5.4. So this lady's doing a lot better. That chronic infections get down there. Now, her symptoms were a little better, but not tremendously better. But the blood work showed us, her and me informed us, hey, you're getting better. And so therefore we were able to continue with care with her. And she stayed with us for some months after that. And she got where she needed to be. She got much better. All right, so all right, so 8-year-old female with warts on the bottom of the foot. Well, that comes from HPV. There's different strains of HPV. So additional history. Mother reports that child has not felt well since that time. So 6 months prior, 8-year-old female gets warts on her feet. And at that time, she got tired. Well, warts is a virus. She got tired, but she's been tired ever since. Now, what happened was they were getting ready to go on vacation. So, and they'd been to the medical doctor 3 times with her over the last 3 months to burn the warts off, but they kept on growing back. And so remember, they're cutting off the branches of the tree, but they didn't get to the root of the problem. And so she said, is there something you can give her? You know, so maybe we can go on vacation. Maybe she's just doing better. And when she comes back, we'll do a full workup on her. I said, that sounds fair enough, but let's at least run a CBC, see what she looks like. Well, this is what the foot looked like. And then the mom was a patient. Then we did the CBC. A CBC was, and a virus was confirmed. I suspected HPV. As they generally cause warts. I started the 8-year-old on a homeopathic for HPV and an antiviral formula. It had things like, oh goodness, I don't even know, olive leaf extract and stuff like that. So her white blood cell count was a little bit low for an 8-year-old. The platelet count was above 250, and lymphocyte, you know, should be 60-30. She's 49-39, so she's about 40. So she has, that does fit, and her monocytes are right. That fits a pattern of a virus. So the bottom of the foot, and so I gave him those things. And then the bottom of the foot had completely healed within 2 weeks. So that's what it looked like in 2 weeks. Just amazing how that turned around, just doing a little bit of homeopathy and a little bit of herbs. Body just needed a little help. So, well, she comes back in, she's still tired. So I said, okay, well, let's do a workup on her. And I did general blood on her. And look at these numbers. This is the 8-year-old. Look at these numbers. So remember, the triglyceride to HDL ratio is going to show us about insulin resistance. And it should be lower than 3.0. And if you look at 284 divided by 29, that's about 10. So she's over 3 times what she should be in there. And she is overweight, and she's got insulin resistance, bad, right? So for a kid 8 years old, we want the creatinine to be at least 0.5. Even with all this weight, she has low muscle mass. That's a sign of low muscle mass. Get our autistic kids and spectral kids, you want to make sure that creatinine is above 0.5 because you want them to have good muscle mass. So our TSH was 11.1. So that's pretty bad. Like, that's an 8-year-old. And there's a part I didn't tell you. The mom has Hashimoto's. So I had some suspicions there, but 8 years old. And then we did antibodies, and her thyroid antibodies should be lower than 9. They were above 900. They were above 900. Now, if you see this, the virus, you know, it was at 39, call it 40. The virus was getting better. The white blood cell count 6-7. It's coming up. So the virus has gotten better. But guess what? And this is what we're going to go over when you come to the autoimmune module on May 16th, 17th, is we're going to talk about how this virus in her actually activated this loss of of self-tolerance. That's what autoimmune is. When the immune system has lost self-tolerance, it no longer recognizes the body. It thinks the thyroid is that virus, and it's going after that virus. It thinks it's going after the virus, but it's actually attacking the thyroid. So this child actually has Hashimoto's. And I have to, and I said that a while ago. I want to make sure I'm right. Yeah, May 16th and 17th. I want you guys to make sure that you're signing up for that. I'm going to go through one more case that I think is interesting. I've got a bunch of cases here. By the way, this is oral DNA. You can do what's called MyPeriopath, and it'll show it. Basically, if somebody has this yucky looking thing in their mouth, and I didn't see it, that receding gum, you have them take this liquid that this lab will give you, swish it around 30 seconds, spit it in, and then they will show you if there's bacteria, periodontal disease. Periodontal disease can relate to diabetes, cardiovascular disease, dementia, and a whole bunch of other stuff. This is a pre and a post. And the purple is the really bad one here. So if you look at that, that was, and this person had to go to a dentist and had to do different things to ameliorate. Okay, so I want to do one more case if you guys can hang with me here. So 47-year-old female presents with rapid onset facial numbness and tingling. What are you thinking there? Stroke, TIA, right? Significant heaviness in both arms. Well, we thought stroke, but now it's heaviness in both arms. Strokes don't do that, most usually, right? Pressure in the back of the head. So we didn't know what it was. So they went to the hospital. She went to the hospital, emergency room. She got a CT of the brain, the head, and the neck, and nothing showed up. So they did a series of labs. And look at this. Her white blood cell count is 8.74. And what have you learned so far in this course, right? Her platelet count was above 250. Neutrophils above 60. There's some hallmarks going on here, right? Total protein, look at this, 8.1. I will guarantee this patient has a bacterial infection. Absolutely. And it's probably what's driving this. All right, so look at this. Bacteria in the urine. She had a 4+ bacteria in urine. Now keep in mind, bladder infections can mimic anything. They can do anything. People have leg pain, people have brain problems, people have joint pain. If you have a postmenopausal lady, you want to run a urinalysis on all of them. They can have these low-grade infections, or this is a very active one. So then she comes into the office a few days later because she got no answers there. And I repeated the urinalysis, and sure enough, she still had bacteria in there. And so this is, actually this happened a few years ago, but this is September 10th when we collected it. We collected this one September 16th, and the bacteria is gone. We did some vitamin C IVs, did a couple of vitamin C IVs, did some liposomal vitamin C and some silver, and all the symptoms went away. This was simply from a bladder infection. All right, so I've got a whole bunch more of these to actually go through. I'm sorry I was not able to get through all of them. Actually, we did get through most of them, so we're pretty good here. All right, so just wanted to make sure, I'm going to open this up to make sure anybody has any questions. I'm going to look and see if any questions have been put out there. Guys, thank you so much. I've enjoyed going through this. I may follow up next time and go through some treatment things, some protocols that we can use for infection. Right now, the purpose that I wanted to go through here, and I think we've accomplished it, is to get this understanding about how to identify the possibility of chronic infections. And I want you to start working this out. Start looking at your patients, especially ones with chronic pain, chronic joint pain, fatigue, you're just not getting anywhere with them. You've done all the stuff, not getting anywhere. Start looking at these labs and see what's going on, and look and see. By the way, last thing, always suspect the mouth. If somebody's had a root canal, let's say they've had a root canal in this tooth, have them tap that tooth, and then have them tap the one behind it and tap the one in front of it. If the root canal tooth they tap and it feels different, that's an indicator they've got a chronic infection in there. They need to see a biological dentist. Don't see a regular dentist because they'll miss it every day, all time, day in, day out. They miss it all the time. Even if they have a CBCT, they don't know how to read them. You got to go to a biological dentist. We have a great one in St. Louis. His name is Dr. Ramey. We sent numerous patients up there. I've gone up there myself, and look at the periodontal disease. Look in the ears. Make sure they don't have fluid in their ears. Make sure it's not coming from the sinuses. Look at their throat. Make sure they don't have white pockets on their tonsils. See where their symptoms lie. See if you can root out where it's coming from, and you'll be a real hero to this patient, because I got to tell you, these things are commonly missed. These things are commonly missed. And the last thing I'll say about it is this. If you have somebody that appears that they have a virus going on, they feel great, they have plenty of energy, all their blood looks fine, except for they've got a few of these things off. Maybe their neutrophils are chronically at 40, and their white blood cells at 4.8, something like this, but they feel great. They have a lot of energy and this and that. What I'm going to say is, I'm less aggressive at going after those infections. I don't want to just root them out, because sometimes you can cause more problems than you really help. Best thing to do with these patients is just get them on a good overall health thing, blood sugar boot camp, bail them out, get them healthy, get them exercise, get them sleeping, and let their body take care of that over time, instead of trying to get in there and just root it out. Now, if somebody has active symptoms or chronically fatigued, they can't, you know, the joint pain, this and that, then I'm going to be more apt to go after them. All right, May 16th and 17th. Guys, thank you so much for watching this webinar. It's been a treat to do. We will see if we can get the recording up, and maybe you can watch it again. God bless, and we'll see you on May 16th and 17th.